Hello, and welcome to a webinar from CFR Journal. Today's program will focus on innovative approaches to mineralocorticoid receptor antagonist therapy. My name is Vijay Chopra. I'm a Director, Heart Failure Program and Clinical Research at Max Hospital, Saket in New Delhi. And it's with great pleasure that I have to say that we are joined today by a fantastic faculty. Dr. Javed Butler is the president of Baylor Scott and White Research Institute, senior vice president for the Baylor Scott and White Health, and professor of medicine at the University of Mississippi. Welcome, Dr. Butler.
Delighted to be here.
And next we have Dr. Dinesh Khullar, who is chairman of nephrology and renal transplant at Pan Max Hospitals in Max Hospitals in India. Welcome, Dr. Khullar. And finally, we have Dr. John McMurray, Professor of Medical Cardiology and Deputy Director of the Institute of Cardiovascular and Medical Sciences at University of Glasgow. So warm welcome to everybody. This is to be an interactive session, which will feature polls and audience question and answer programs. So please feel free to submit your questions to the faculty via the question module on the web page, and we'll endeavor to answer as many of them towards the end of the webinar. So coming to today's program, if ARNI dominated the headlines from 2014 onwards, thanks to the paradigm trial, and SGLT2 inhibitors from 2019 onwards, starting from EMPA-REG, DAPA-HF, and EMPEROR series of programs, it appears that aldosterone antagonism will occupy prime space in the next 2 or 3 years at least, thanks to a large number of trials exploring different mechanisms in this space, whether finerenone, aldosterone synthase inhibitors, or aldosterone receptor modifiers alone or in combination with SGLT2 inhibitors. And the reason is that globally, despite their proven utility, aldosterone antagonists have not been used as widely as they should have been, considering their strong cardiorenal protective effects. Two factors which have held them back have been hyperkalemia and the fear of worsening renal functions, and this has resulted in underutilization in some of these patient populations which could have benefited the most. So this webinar is designed some of these issues. So let me first invite Dr. Butler, who's going to tell us about the methods of overcoming clinical barriers with aldosterone and potassium. Dr. Butler, over to you.
Thank you very much, Dr. Chopra, for that kind introduction and also for the invitation to speak to all of you. Very much appreciate the opportunity. The topic that I will be talking about in the next 10 minutes is overcoming clinical barriers with aldosterone and potassium. My disclosures are at the bottom of this slide. So let's just start first with aldosterone. Modulating aldosterone has been part and parcel of cardiovascular and lately for chronic kidney disease practice for a very long time. We have known for over 30 years that the higher the aldosterone levels, the worse the outcomes for patients, both from cardiovascular or chronic kidney disease perspective. Whether you look at the patients with heart failure and reduced ejection fraction, whether you look at heart failure with preserved ejection fraction, you look at resistant hypertension, you look at hospitalized patients, you look at outpatients, aldosterone levels are associated with worse outcomes. And indeed, that is precisely the reason that over the past 3 decades, we have had a plethora of clinical trials that have targeted aldosterone modulation in some way or another. We have therapies related to either ACE inhibitors or ARBs or ARNI, which also have ARBs, may have some effect on aldosterone. However, we do have a mechanism of aldosterone escape. In other words, although angiotensin II is a one of the biggest modulators of production of aldosterone. With ACE inhibitor reducing the angiotensin II levels, the body have escape mechanisms, and that's why we needed to add specifically MRAs in our armamentarium. So we have trials that are positive in patients with mild to moderate heart failure, with severe heart failure, with post-MI heart failure, and more data have come out in heart failure with preserved ejection fraction as well. So RAS modulation, either with ACE, ARB, ARNI, or aldosterone-specific modulator, we have plenty of data that it improves outcomes for patients. And as we mentioned, now that we are thinking more about the cardio-kidney metabolic syndrome and understanding that these neurohormonal activations not only are specific for various forms of cardiovascular diseases, they impact multiple other organ systems as well. And now in the CKM era, KDIGO guidelines also recommend RAS inhibition and non-steroidal MRA in CKD patients as well. Indeed, if you look at the guidelines, there are class 1 recommendations for the use of RAS modulation and for MRA therapy. These are the recommendations in American guidelines, European guidelines, Asian guidelines, or kidney guidelines, cardiovascular guidelines. So there is no doubt that aldosterone modulation is of significant importance. And not only should we be giving these therapies, there is a little bit of a rush as well, not to wait to give it up front. These are the data from STRONG-HF showing that early initiation of optimal medical therapy within a matter of 6 months can improve the outcomes for the patient substantially. So now that it's a class 1 recommendation, the question is, what do you do if a patient is unable to take the medications altogether? If the patient can take only one or the other, either an ACE inhibitor or an MRA, or can take the medications but not at the doses that are recommended, what do you do in that case? Well, not only the first two questions are pretty self-explanatory, that if a person cannot take the doses, cannot take the medications that are recommended, then that person will be at a higher risk for adverse outcomes. But there are actually dose data as well, that it's not only imperative to give the right medications, but the right doses. We have two trials, one with ACE inhibitor that is being shown here, showing that when we go from low doses to high doses, there are further reductions in the risk of hospitalization. And these are the data from ARB, again showing the same thing, that moving from low doses to high doses, there are further benefits in terms of risk modulation for hospitalization. So not only is it important to give the therapy, but give at the doses that are recommended. And although we have seen that in the clinical trials, if you look at the real world data as well, not giving the medications or low doses of medications are associated with worse outcomes, as opposed to giving the medications and giving them at optimal doses. So if we all agree that the medication should be given, then what is the problem? And the problem is what Dr. Chopra mentioned in his introductory comments, that there is a fear and there is a reality of the risk of hyperkalemia and worsening kidney function. In fact, even cutting down the doses is associated with worse outcomes, not only for heart failure, but kidney disease progression as well. While we have the data for ACE inhibitors and ARB in terms of the doses, we don't have the dose response data for MRA. But you know why we don't have the dose response for MRA? The reason why we don't have dose response, because we couldn't do the studies. We know that we are not giving full doses of MRA. We know that because higher doses are associated with more modulation of neurohormonal activity. We know that if you want to give somebody with cirrhosis for natriuresis, you give 100 milligram. But the reason we give 25 milligram is because of the risk of hyperkalemia. And in practice, a lot of the times people give 12.5 every other day or something like that, and we have no idea what is the benefit of that. MRA has a dose-dependent increased risk of hyperkalemia overall, And that is in the clinical trial setting where a lot of the patients were excluded who may be at higher risk. And if you look at the clinical practice, the risk is even higher. Now, the issue here is that, one, we need to maintain potassium somewhere in the middle between 4 and 5 because hypokalemia is also puts the patients at higher risk. The irony, however, is that our patients with hypertension, diabetes, CKD, heart failure who need therapy the most, who are at the highest risk, also tend to have lower GFR and a higher risk of developing hyperkalemia. The other problem is that there are very few patients who have one episode of hyperkalemia because they took some extra potassium supplementation or took some drug that had an interaction with it. Most patients will continue to have recurrent hyperkalemia, and the reason for this recurrent hyperkalemia, the second, the third, the fourth, is because not only the phenotype that puts the patients at high risk of hyperkalemia is the very phenotype that will persist, but over time it will actually worsen. Remember, with age and other comorbidities, GFR tends to go down. So we need some solutions that are long-term because this is not a one-time problem overall. And as mentioned, those patients with CKD, diabetes, heart failure, they are the ones that are at higher risk. And you add age on top of that, the risk continues to escalate. Now, the other issue is that while the guidelines may say as much as they want to say that, for potassium between 5 and 5.5, watch and lower the dose over potassium of 5.5, in reality, even between 5 and 5.5, over half the time the doses are reduced or are discontinued. And as a clinician, that makes sense to me. It's okay for the guidelines to say watch the patient. But you may have older patients, you may have patients with dietary indiscretion, you may have patients who may not be able to come to the clinic for follow-up labs. You may have patients with borderline GFR. For a whole bunch of reasons, you don't want to take the risk. So, what do you do? Well, if somebody is at risk of developing hyperkalemia or they do develop hyperkalemia, what the guidelines suggest is to use all the things that we have in our armamentarium. And I'm talking about chronic hyperkalemia, not acute hyperkalemia. Chronic hyperkalemia, do everything first before we cut down the dose of RAS inhibitor or we stop the therapy. So make sure they're not on potassium supplements, make sure they're not on some other drugs that may have drug-drug interaction, make sure that they're not volume depleted with a bump in their GFR, make sure they're not taking non-steroidals or other medications that may impact renal function as well. Finally, though not ideal, at least try to give lower doses before you go ahead and stop the medication altogether overall. This is exactly what is recommended in both the heart failure and the CKD guidelines, that if somebody develops hyperkalemia or at risk for it, do other things first and don't automatically stop the RAS inhibitor because these are life-saving medications. So review medication history, titrate the doses, maybe some other therapies that can take care of hyperkalemia. But in this day and age, hyperkalemia should really not be a reason to stop RAS inhibitor because we do have effective potassium binders. There are 2 effective potassium binders that in real life patients that are eating, drinking, whatever they want, they may have comorbidities, they may have other RAS inhibitors and MRA, but sodium zirconium cyclosilicate that exchanges sodium for potassium for sodium in the gut across the entire lumen, and patiromer that does so, but it exchanges with calcium more so in the colon. Both of them are very well tolerated, not absorbed, and can maintain potassium levels while RAS inhibitor therapy is given to the patients. So I will end by saying that aldosterone modulation is a centerpiece of management of heart failure and CKD patients and hypertension and post-MI patients. Let's try to do everything we can to put these medications on board. There are some other therapies that are being tried where the risk of hyperkalemia may be lower despite modulation of aldosterone system. And finally, if nothing is working, consider using potassium binders. Thank you very much again for giving me a chance to speak today.
Thank you, Dr. Butler, for your very lucid presentation. And now I would like to hand you over to Dr. Khullar, who's going to cover clinical evidence and implementation of non-steroidal MRAs. Dr. Khullar, over to you.
Thank you very much, Dr. Chopra, and thank you for the wonderful opportunity. Over the next 10 minutes, I'm going to talk about the novel non-steroidal mineralocorticoid receptor antagonists, the first generation, that's finerenone, and what kind of clinical evidence we have so far, and does it really help in our strategies as far as implementation of this is concerned. So, well, I will take you to the absolute basics where we have tried to figure out as to what is really contributing towards the kidney failure and heart failure, especially in patients who are diabetics, type 2 diabetics. And we have been focusing more and more on hemodynamic and metabolic factors all these years, trying to figure out as to what hits the kidneys and the heart more as compared to other factors. But what we have realized over the period of time is the role played by the inflammation and the fibrosis. And we have also realized the relative importance of mineralocorticoid receptor overactivation, which contributes to just the kind of final outcomes we have in terms of fibrosis and cardiac remodeling in these two organs. So with that in mind, we have the novel mineralocorticoid receptor agonist, which is finerenone, which is certainly a huge improvement on as compared to the traditional steroidal mineralocorticoid receptors, because there were some issues related to that, especially in terms of the kind of androgenic side effects, the sexual side effects which were having the steroidal ones, and also the relatively higher risk of hyperkalemia. So finerenone has been built to take care of most of them, as I'll show in the subsequent slides. But at the level of the kidneys, the various functions which they have been shown to have is at the level of the glomerular hypertrophy and sclerosis, also at the level of sodium retention and alterations of sodium-potassium pump driven by the mineralocorticoid receptor activation by the aldosterone. And at the level of the heart, you can also see the kind of positive effects they can have as far as the reduction of cardiac hypertrophy, and of course indirectly via blood pressure control, leading on to improvement in both the systolic as well as the diastolic dysfunction. Well, this is what I was talking about. The finerenone has been a big and a nice addition to the repertoire which we have in the management of these patients, especially because it is much more selective for the mineralocorticoid receptor as far as the traditional ones are concerned. It's highly potent when it comes to the anti-inflammatory and the anti-fibrotic actions are concerned. But what is more important is it has a more balanced heart and kidney redistribution, and we can expect relatively low rates of hyperkalemia, especially in patients with some degree of chronic kidney disease. So the half-life is just about 2 to 3 hours. So certainly we have seen quite a lot of good data with finerenone, and let me over the next few minutes highlight the importance of the kind of data which we have in relation to finerenone. Talking first about where we all started with, and that's the pool data of Fidelio diabetic kidney disease, where the primary composite endpoint was renal and the secondary was the cardiac. And we had the Figaro-DGD trials, and they involved about 6,000 and about close to 7,000 patients respectively, making it a pool data which they labeled as fidelity of about 13,000, which had a wide range of people of all sorts of chronic kidney disease, starting from the absolute the beginning to more advanced chronic kidney disease. And what they could show was that in about 40% of cases, the diagnosis of chronic kidney disease was made just on the basis of albuminuria. So that's the kind of importance one would tend to give to the presence or absence of albuminuria in our patients with chronic kidney disease. And the data was quite impressive. As you can see here, the demographics tell us that there were not too many patients who were on simultaneous usage of SGLT2 inhibitors because they were catching up at that point in time. And I'll come back to that a little later as to what do we have subsequently. But then fidelity outcomes were quite impressive. If you were to look at the composite cardiovascular endpoint, this is over and above the maximally tolerated dose of RAS inhibitors, and you have 14% additional benefits. And when it comes to the kidney endpoints, again, a 23% relative risk reduction. But when you look at the overall outcomes, 1/5 reduction in both as far as the hospitalization for heart failure is concerned and the requirement of dialysis is concerned. So a good news for both the heart as well as the kidney when it comes to the beginning of the data with finerenone. So the other thing which we always were worried about was the risk of hyperkalemia. As you can see here, the risk of hyperkalemia may have been little higher as compared to the placebo arm. However, it did not lead to permanent discontinuation in these patients, and more importantly, it did not cause death in any of these patients. Also equally important was the incidence of the androgenic side effects was virtually very low as compared to even the placebo arm. So moving on, as I said earlier, we didn't have too many patients who were put on finerenone in the pooled fidelity data who were also on SGLT2 inhibitors. And we certainly needed to know as to what happens when we combine the two. And with that in mind, we had the confidence trial, which compared as to what happens when we compare the combination of finerenone and empagliflozin with finerenone alone or empagliflozin alone. Well, interestingly, it showed that when you had given these patients the combination of both finerenone as SGLT2 inhibitor, you could expect 32% greater reduction as compared to when AMPA was used alone, and about 29% greater reduction versus finerenone. So obviously, in 2025, you would want to use all the effective tools which you have available to you, trying to help these patients, especially bringing down their protein excretion, because we have enough data which tells us that that's the best thing we can do for these patients, resulting in better outcomes in the long run. Well, what is quite clear now with more and more data creeping in is that if you use the combination of SGLT2 inhibitors and finerenone over and above RAS inhibitors, it's a good news for the heart as far as the hospitalization for heart failure is concerned, an improvement by about 6.9 years. And when you look at kidney failure, another close to 5 years of benefits, and all-cause death, again, you get benefits to the tune of 2 years. So quite impressive data. So it speaks that we should look at the combination rather than any therapy alone. And obviously, we will have to take care of the associated fears of hyperkalemia, and the way Dr. Butler has alluded to. So coming to what finerenone has been able to demonstrate as far as the heart failure is concerned, the most recent data from Fine Arts Heart Failure, which evaluated the efficacy and safety of finerenone in patients with heart failure where the ejection fraction was more than 40%, the New York Heart Association class 2 to 4, and where we could demonstrate structural heart abnormalities within the last 12 months. Again, very impressive data. If you look at this chart, which shows that 16% relative risk reduction could be demonstrated in the composite of cardiovascular deaths and total heart failure events. So again, quite impressive, where you were looking at the positive effects of finerenone in patients who had heart failure. But then interestingly, these patients did not have much of kidney disease. Their estimated GFR was 61, and the median albumin excretion rate was about 18. So the kidneys did not stand to gain much when they were not significantly affected, but in terms of what the drug can do to the heart, quite impressive, especially when it comes to the total heart failure events first and the recurrent ones, and the change in the Kansas City cardiomyopathy questionnaire total symptomatic score. So again, great news from the both heart and the kidney point of view, and that's why the guidelines talk quite excitedly about the use of finerenone in both chronic kidney disease and heart failure, and we can expect it to be the new pillar, as we had those 4 pillars while managing left ventricular ejection fraction less than 40% for the HFpEF. We probably have finerenone doing a great service to our patients. To conclude, the mineralocorticoid receptor overactivation contributes to both inflammation and fibrosis, and this is a pathway which has been very effectively taken care of by finerenone. This is what we hear from it as far as the kidney protection and the cardiovascular benefits are concerned, and we have realized that there's an additive effect when we combine this with SGLT2 inhibitors, and certainly Finex has shown it's a great news for patients with HFpEF. So that's why it's been strongly recommended across major international guidelines for type 2 diabetes and chronic kidney disease. Thank you very much.
Thank you, Dr. Khullar, for your presentation. And now it's my great pleasure to invite Professor McMurray, who's going to cover aldosterone synthase inhibitors in hypertension and heart failure, the hot topic today. Dr. McMurray,
thank you very much. Thank you very much, Vijay. So you've heard about the past and the present, and my job really is to talk about the future potentially of anti-aldosterone therapy. In other words, aldosterone synthase inhibitors. These are my disclosures. And this is an outline of what I want to talk about. So I want to talk about, well, why should we think about developing another type of anti-aldosterone treatment? What is the effect of these drugs in hypertension? We have evidence already about this. And then I'm going to talk about these drugs as a potential treatment for heart failure, and even as a potential treatment to reduce the incidence of heart failure, in other words, as a heart failure prevention therapy, although these remain hypothetical. We don't yet have evidence. So why do we want another type of anti-aldosterone therapy? Well, when you block any receptor, you get a counter-regulatory increase in the receptor ligand, in this case aldosterone. So during chronic mineralocorticoid receptor antagonist therapy, MRA therapy, you get high levels of aldosterone that may overcome the receptor blockade. Also, the MR receptor isn't just activated by aldosterone, but is activated by other corticosteroids, and those corticosteroids acting on that receptor may have effects that we don't want to block. We might prefer to more selectively block just the effect of aldosterone, and you can't do that with the mineralocorticoid receptor. It's a non-selective receptor. And then, of course, as you've already heard from the 2 previous presenters, some MRAs have off-target effects. The best recognized off-target effects, of course, are the estrogenic side effects, such as gynecomastia and so on. But maybe the single most important reason that we might wish to block the effects of aldosterone in a different way is because aldosterone may mediate effects not through the conventional MRA receptor, but in other ways. These are so-called non-genomic effects. So we refer to the traditional effects that we understand, increase in blood pressure, sodium and water retention, and so on. We refer to those as genomic or receptor-mediated effects, but aldosterone is believed to have non-genomic effects not related to activation of the aldosterone receptor. And this was recently discussed in a nice New England Journal editorial here pointing out that the non-genomic effects might include things like oxidative stress, and maybe effects like fibrosis, etc., are actually non-genomic effects. So, of course, an MRA receptor, mineralocorticoid receptor antagonist, will not block those non-genomic effects. You would have to reduce the production or synthesis of aldosterone to block those non-genomic effects. So this is hypothetical. This has been demonstrated in animal studies, but we don't really have as yet human evidence for this. But that is the principal hypothetical reason why aldosterone synthase inhibitors might have advantages over MRAs. Well, do aldosterone synthase inhibitors work in human beings? And the only real evidence we have to date about the effect of these drugs is actually in hypertension. And this is one trial that got a lot of publicity when it was presented a few weeks ago at the European Society of Cardiology. This is a trial in 794 adults with uncontrolled or resistant hypertension. And these 794 patients were randomized to one of two doses of baxdrostat, that's an aldosterone synthase inhibitor, or placebo. You can see the other inclusion and exclusion criteria on that slide. So about 27% of these patients had uncontrolled hypertension, 73% had resistant hypertension. The median number of antihypertensive drugs these patients were taking at baseline was 3. Almost all of them were an ACE inhibitor or ARB, 70% on a calcium channel blocker, 34% on a beta blocker. You can see that half of them were obese and more than a third of them had diabetes, typical sort of resistant hypertension population. So here you see the effect of baxdrostat on the primary endpoint in this trial, which was change in seated systolic blood pressure at week 12. And the placebo group is shown here in grey. The two baxdrostat dose groups are shown in yellow and orange. So 1 milligram is yellow, 2 milligrams is orange. And you can see that compared to placebo, aldosterone synthase inhibition led to around a 9 to 10 millimeter reduction in systolic blood pressure by 3 months, a pretty impressive, robust reduction in blood pressure. This benefit was consistent across all the subgroups looked at in this trial. There were favorable effects on ambulatory blood pressure, and of course, aldosterone synthase inhibition led to a reduction in circulating blood levels of aldosterone. The interesting thing about this trial was that it had a withdrawal phase, and after withdrawal of baxdrostat, blood pressure remained reduced for a considerable period of time, as did aldosterone levels. So no question that this type of treatment is an effective blood pressure reducing treatment. What about safety? So I've shown you efficacy. What about safety and tolerability? And here you can see what we're most interested in, hyperkalemia. So Javed talked about this a few minutes ago. You can see that there was an increase in hyperkalemia, although the risk of confirmed serious hyperkalemia, defined as a potassium greater than 6 on repeated measurement, was pretty low. Around 1% of patients had this after 12 weeks of treatment. But no question that these drugs also cause hyperkalemia, like mineralocorticoid receptor antagonists do. Now, I've shown you a trial with baxdrostat. There is other evidence that other agents in this class reduce blood pressure. And here is a series of trials with another aldosterone synthase inhibitor called lorundrostat, which also, as you can see here, reduces blood pressure significantly. So these drugs look like interesting, novel antihypertensive agents, and I would say undoubtedly will be approved for that use probably in the next few months. But what about the future? What about other cardiovascular roles for these drugs? And in particular, what about aldosterone synthase inhibitors as a treatment for heart failure? Well, you've heard about and you know about the really impressive effectiveness of mineralocorticoid receptor antagonists in patients with heart failure and reduced ejection fraction, the older steroidal MRAs. So, of course, we hope that the same can be shown for aldosterone synthase inhibitors in heart failure with reduced ejection fraction. And you can see here in this slide that there are many, many trials underway with novel anti-aldosterone treatments, including a trial with an aldosterone synthase inhibitor in patients with heart failure and reduced ejection fraction. Javed Butler is involved in these EASY heart failure trials. This is the EASY heart failure with reduced ejection fraction trial, a 4,200 patient trial comparing Vicadrostat plus empagliflozin to empagliflozin alone on top of all the other evidence-based treatments we have for this type of heart failure, looking at a conventional heart failure composite endpoint, and that trial is currently recruiting. The great thing about these EASY heart failure trials is that they have a patient-facing website. I've screenshot some of the pages from this, encouraging patients to actually get in contact so that they can be connected with a local investigative site to take part in this trial. And similarly, there is a trial like this in patients with heart failure and mildly reduced to preserved ejection fraction. We, again, as you've just seen in the last presentation, have evidence that one of the newer non-steroidal MRAs can reduce events in these patients. And we hope that we might be able to show the same thing with aldosterone synthase inhibitors. And there is a sister EASY HFpEF trial. And again, this is using the same aldosterone synthase inhibitor, this time in a bigger trial, because of course these are lower risk patients. So this is about the same size as the Fine Arts HF trial, again, comparing Vicadrostat plus empagliflozin to empagliflozin alone, again, with a conventional composite heart failure endpoint in the same patient-facing website, encouraging people with heart failure to contact the trial and be put in contact with a local recruiting centre. And finally, I think maybe the most interesting aspect of these new drugs is that they've given us a tool to test a strategy that we wanted to test for a long time, and that is a heart failure prevention strategy. Can we prevent heart failure, not wait for it to develop, not wait for patients to be really ill and in the case of reduced ejection fraction, a very high mortality risk? Can we actually prevent the development of heart failure? And there was an interesting series of articles about this in The Lancet recently. And I'm very pleased to say that there are 2 large trials underway testing the role of aldosterone synthase inhibitors as a potential treatment to prevent the development of heart failure. You can see the design of these 2 trials here, very, very similar design, similar size, similar endpoint, different, of course, aldosterone synthase inhibitors. Again, both of these trials comparing the combination of an aldosterone synthase inhibitor and SGLT2 inhibitor to an SGLT2 inhibitor alone, on top of other appropriate cardiovascular therapies. And the reason, again, these trials are using this combination is because they're both enrolling patients with type 2 diabetes. Patients also have to have a history of hypertension and have to have established cardiovascular disease, of course, excluding heart failure. And the composite outcome in both of these trials is cardiovascular death or development of heart failure. So 2 trials that will tell us, can we actually prevent heart failure, which I hope we can. And then just to show you again that there is a patient-facing website for the Easy Protects trial, again using this, I think, novel and interesting approach to encouraging enrollment. I don't want to forget to mention, it wasn't in my remit to cover, but it is important to mention that, in fact, there is a trial using an aldosterone synthase inhibitor in patients with chronic kidney disease to prevent both kidney and cardiovascular outcomes. Or sorry, there are 2 trials, one with baxdrostat and one with becadrostat, and we can maybe talk about these in the discussion if you would like to. So to summarize and conclude, aldosterone synthase inhibitors have theoretical advantages over mineralocorticoid receptor antagonists, but these really are unproven in human beings. There's no question that ASIs are effective antihypertensive treatments, but they've never been compared to date, and I doubt if they ever will be compared, at least for a long time, to mineralocorticoid receptor antagonists. So we don't really know about their respective efficacy and safety. As I've shown you, there are trials underway looking at the potential for aldosterone synthase inhibitors to be a treatment for both HFrEF and heart failure with mildly reduced and preserved ejection fraction. But again, these are comparisons with placebo, and we will not have, and probably will never have, a direct comparison to MRAs. And then finally, as I said, there are 2 new very large trials testing the role of aldosterone synthase inhibitors as a treatment to prevent the development of heart failure. And these are currently recruiting. And thank you very much indeed if you are enrolling in these trials. So thank you for listening.
Thank you, Dr. McMurray, for that wonderful presentation. So let's have a little discussion. We still have about 15 minutes to go. So Dr. Butler, let me start with you. At what level of hyperkalemia would you like to introduce these therapies to reduce potassium, considering their cost? Would you jump in at 5.5 or would you wait till 6 or what?
Yeah, I'm not going to give you the answer because I think it really has to be individualized, and it's actually not only need to be individualized to the patient, older patient, lower GFR, those sort of things, but it also has to be individualized by the clinician comfort level also. So I would say, if you are willing to compromise on RAS inhibitor therapy, either angiotensin II modulation or aldosterone, before you do that, use a potassium binder if available. In my opinion, in this day and age, the only reason to not give an ACE inhibitor or an MRA is not unable to access a potassium binder. And I completely agree with you, the cost considerations and other considerations are there. But some people may have a threshold at 5.5, some people may have a threshold of 5.2, and that has to be individualized.
And between the 2 agents available, patiromer and sodium zirconium, is there a comparison, or which one do you think is more effective?
I mean, at least from my perspective, if you can get your hands on either of the 2, that's good enough. A couple of points. So, sodium zirconium cyclosilicate acts across the GI tract, so has a little bit of a faster onset of action. Patiromer is only in the colon, so a little bit slower onset of action. But remember, we're talking about chronic hyperkalemia management, not acute hyperkalemia. So, an R here or there probably doesn't make a difference. There is a sodium load because remember, the patiromer exchanges potassium for calcium, whereas sodium zirconium cyclosilicate exchanges potassium for sodium. So there is a little bit of a sodium load. There are data that at higher doses you have edema, you have some changes in natriuretic peptide levels. So if you have a really sick patient, decompensated, semi-decompensated, and the potassium levels are such that you will need to use more than 5 milligram doses, then patiromer may be more preferable. But if you're using low doses, which is usually the case in most patients, I would say just use whatever you can get.
Vijay, could I ask a question?
Yes, please.
Has the podcast trial that was presented at ESC changed people's opinion about potassium? So this was a trial deliberately targeting increase in potassium in people vulnerable to ventricular arrhythmias, but that included, I think, about 2/3 of patients in that trial with heart failure, and the intervention to increase potassium did seem to reduce the rather complex composite endpoint that included ventricular arrhythmias, appropriate ICD discharge, hospitalization with arrhythmias, and indeed hospitalization with heart failure.
Vijay, do you mind if I respond?
Yes, please.
Yeah, John, I mean, really good point, right? So we know, classically speaking, we have talked about hypokalemia as less than 3.5, but we know that the risk of arrhythmias go up at less than 4, so we should really try to keep it more than 4. And actually, many people would argue that the reasons MRA work is actually by raising the potassium levels overall. If I'm not mistaken, the podcast, they ended up with a potassium of about 4.8, so upper level of sort of normal, but not in the 5s per se. It's the 5s that make people uncomfortable. But your point is very well taken that we not only say this theoretically, but now there is actually in vulnerable patients for arrhythmia a full clinical trial, randomized trial, that maintaining mid-5 and above may be a good thing. It's just that over 5 when there is a risk. The other thing is that I've heard this a lot of times that CKD patients have chronic hyperkalemia and that it is better tolerated, whereas in heart failure, there is a more rapid shift and that is less tolerated. I don't know whether there is sort of real science or data behind it. It kind of maybe makes sense. But again, in the heart failure population, I think most people would want to keep it somewhere between, 4.7, 5.2 range.
Dr. Khullar, do you think chronic hyperkalemia is better tolerated?
Yes, that's for sure, and we at times encounter that very, very commonly. Our dialysis patients tend to tolerate hyperkalemia much more easily as compared to acute. So acute is a different ballgame altogether, and chronic actually makes us little complacent because so many times we come across terribly high potassium reports. We continue to see those kind of reports in a given patient, and since it's not troubling them, we tend to become complacent, although we tend not to do that very often. But then, yes, something like 5.5 to 6 is better tolerated by patients of chronic kidney disease who have, where the heart has become more used to the chronic effects of hyperkalemia. But then I would like to add, Dr. Chopra, here, with your permission, that you see the point that Professor McMurray has raised. Should not forget the positive effects of potassium when it comes to the blood pressure control. So on one hand, we are wanting to go low. At the same time, we do realize that there is a relative importance of the positive effects of potassium as far as the control of blood pressure is concerned. So we cannot. And then again, when we are looking at hyperkalemia, what typically comes in a nephrologist's mind is, of course, take care of other confounding factors, but also that means diet included, but also take care of some easy to do things like adding thiazides, adding or the thiazide-like diuretics, which also proved to be quite effective, even before jumping onto the costly drugs like Petiromer or Lokelma.
And for us in our heart failure patients, obviously we should be giving them an SGLT2 inhibitor anyway, but if you've forgotten to do that, that's a treatment that reduces potassium. And sacubitril valsartan reduces potassium compared to a RAS blocker by itself. Neprilysin inhibition reduces potassium. In fact, we saw more hypokalemia in the paradigm trial in the sacubitril valsartan compared to an enalapril group. So I agree. I mean, I think potassium isn't all bad, and there are other things you can do before having to resort to a binder.
Vijay, may I ask a quick question?
Yeah, please.
Let me ask this question to Dr. McMurray, but if Dr. Khullar or you may have an opinion also. So the hypothesis for ASI, that it's the non-genomic effects that you're targeting, the non-genomic effects are both through the MR receptors and non-MR receptors. Are we primarily targeting the non-MR receptors, or do the MRAs preferentially have genomic effects only and non-genomics even through the MR receptor?
So non-genomic effects, and Javed, I am no basic scientist, as you know very well. So what I know, I've actually read as opposed to studied myself. But the non-genomic effects, if there are such effects in human beings, are supposed to be mediated both through the MR receptor and independently of the MR receptor. I was trying not to be skeptical in my presentation because, of course, I think you and I have seen very similar stories for angiotensin receptor blockers compared to ACE inhibitors, for direct renin inhibitors compared to ACE inhibitors and ARBs. And I really don't know whether this is a story that genuinely has legs or whether it's one of those nice hypothetical tales that never actually turns out in clinical practice. But on the other hand, I suppose it always helps to have choices, and we may find a niche for these drugs. Let's see. But in the absence of head-to-head trials, which I doubt we're ever going to see in the patent life of these new agents, we're never truly, I think, in human beings going to find out whether the spectrum of effects is really different or not. I don't know. What do you think?
No, exactly sort of on the same page. I think a more attractive hypothesis for me, again, unproven, is not only the non-MR mediated non-genomic effects, but I think what's interesting is that when we give 25 milligrams of spironolactone, are you actually blocking all the MR receptors? We know that the pharmacodynamic effect is more pronounced when you use higher doses. We use only 25 milligrams because of the hyperkalemia risk. So that's the thing that I'm more interested in. Is there more comprehensive aldosterone modulation by lowering the levels? So we'll see.
We'll see.
If I may add, Dr. Chopra, so I think it's quite interesting, the points raised by both of them. And if we individually look at the mineralocorticoid receptor, we know that they are taken care of on one hand by aldosterone and at the same time by others such as cortisol and others. So even if you block mineralocorticoid receptors with the help of aldosterone, the other arm is still unattended to. Now looking at what aldosterone synthase inhibitors are going to do, they are going to take care of both the the genomic as well as non-genomic effects. But the mineralocorticoid receptor activation may still happen with the other arm, which is independent of mineralocorticoid. So which at times gives us a very tempting idea. How about combining the two? And I know that's going to be fraught with huge lot of risks of, especially of hyperkalemia. You can't afford to block everything starting from aldosterone downstream to the MRA. So maybe in the real world, we will evolve and learn as to how to effectively use the way we will be looking at finerenone when the patient doesn't have a very significant hypertension as compared to another patient who has resistant hypertension, where you probably fall back on either the traditional steroidal MRAs or the aldosterone synthase inhibitors.
Yeah, I mean, Bert Pitts and Faiz and Ad have already written to suggest this approach of dual therapy, but I must say, having seen the rate of occurrence of hyperkalemia with aldosterone synthase inhibitors, which doesn't, to be honest, to me, look that different than you see with mineralocorticoid receptor antagonists, I think it might be quite a challenge to think about giving both of those agents together, but who knows? All of these things we'll find out in the next, I would say, 5 years.
John, we are running out of time. So one quick question. What about aldosterone receptor modifiers versus aldosterone synthase inhibitors? Where do you see them? Maybe Javed and you, both of you can jump in.
Well, so I was very interested to see that a recent paper on finerenone, which I think is the only so-called mineralocorticoid receptor modulator. Oh, sorry, I thought we'd disappeared there. Finerenone, which is the only so-called mineralocorticoid receptor modulator I'd ever heard of, I noticed in a recent paper was described as a non-steroidal mineralocorticoid receptor antagonist. So I'm not sure if the terminology's changed and whether or not actually this drug ever was significantly different than the others. But Javed might know more than I do.
No, I don't. It'll be interesting to see how all this evolves.
So now when we talk about using aldosterone synthase inhibitors in prevention of heart failure, reminds me of the story of SGLT2 inhibitors in reverse. We started off by noting that they prevent heart failure, and then we went on to treatment. And now we are treating them and then also looking at whether we are going to be reducing the incidence. There are a few questions in the chat box. Let me see. Will ASIs become first-line agents for hypertensive patients with high CVD, CKD risk, similar to SGLT2 inhibitors in diabetes, to be used along with RAS inhibitors?
Well, I think if our two trials are positive, then the answer is probably yes. I mean, we're going to have very strong evidence and I think have a clear answer. I mean, the two trials are more or less identical in design. They're going to include almost 23,000 patients between them. So if we don't get a clear answer, I'll be amazed. And if the answer is what we hope it will be, then the answer to that question is yes, they will become that. And I imagine, I don't imagine, I'm pretty certain there will be a combination pill that is both an aldosterone synthase inhibitor and an SGLT2 inhibitor given to patients with type 2 diabetes and hypertension for that purpose. Javed, do you agree or disagree?
No, I completely agree. I think where we need to move, I mean, all of these questions have been asked and will be answered in the next few years. What I do find a little resistance in resistant hypertension is why are these drugs only after you fail everything else? And the question in the hypertension world, maybe we should be measuring aldosterone level, not to rule out primary hyperaldosteronism, but just so that we can target upfront therapy with these drugs. But that's for some other time.
And John, finally, the last slide that you showed, about heart and kidney, and you said that we can discuss about it later. Using aldosterone synthase inhibitors in chronic kidney disease. Would you throw some light on that?
Only to say that there are two big trials, so Easy Kidney with Vicadrostat and the Pacific trial with Baxdrostat. Again, they're both combinations, VJ SGLT2 inhibitors plus the aldosterone synthase inhibitor, both with end-stage kidney disease or kidney outcomes and cardiovascular outcomes. Very interesting, because I have to say the recent experience with spironolactone, so conventional steroidal MRA in patients with chronic kidney disease, wasn't a happy one. I think that would be a fair way to summarize it. So it's, to my mind, brave to do these trials, but they are being done. And I think Easy Kidneys, Javed, you may know more about this than I do, but I think Easy Kidneys been recruiting for some time, and I've heard nothing to suggest that any concern has been raised. And if you ever thought there was a group of patients where hyperkalemia might be an issue with these agents, then it's patients with chronic kidney disease.
If I may add, from our own experience, we are part of both Baxdro Arctic, Baxdro Pacific, as well as Easy Kidney trials, and we've been part of the finerenone. I think one thing which really differentiates between the two is the risk of hyperkalemia on one hand, and on the other hand, the blood pressure which comes down quite significantly with Baxdrostat. So we have to be more careful when we set about using Baxdrostat, because we can expect a steep fall in the blood pressure. So I think the chronic kidney disease, although both these trials, the Arctic, Pacific, as well as the Easy with the Vicadrostat, involve patients with chronic kidney disease. Easy is a little more liberal, more inclusive as compared to this thing. But in my capacity as the national lead investigator for both these trials, the Arctic and Pacific, we've had fantastic initial data. But then I think the limiting factor is going to be both potassium as well as the blood pressure. But exciting days ahead, and I'm quite certain they will be great addition to our armamentarium.
I mean, that would be an amazing breakthrough, because I have to say, I don't know what your view about it is, but spironolactone certainly has been disappointing. And if we can get more anti-aldosterone therapies that are tolerated by patients with chronic kidney disease and do improve both types of outcome, that's huge. It really is a massive breakthrough.
Yeah, we didn't hear much about aldosterone after pathway, and of course, with the shifting away from just merely controlling resistant hypertension to offering more cardiac and renal protection, I think it certainly paves the way for the aldosterone synthase inhibitors. Certainly.
I think we are almost out of time now, so I would like to remind the audience that today's proceedings will be available very shortly on demand at www.radcliffecardiology.com. And before we leave, I would like to thank Dr. Butler, Dr. McMurray, and Dr. Khullar for fantastic presentations and for a very lively and informative discussion. And I'd like also to thank our audience for joining us. We hope you enjoyed this webinar and learned as much as I did. Thank you and goodbye.
Thank you very much. Thank you.
Bye-bye.
Bye-bye.